Well, welcome to the second day of our summer session. Hopefully you're all learning and profiting and from your experiences and encounters. It's a great pleasure to talk about who's going to do the seminar today. The topic is painting a whole state purple to prevent abusive head trauma. And our speaker today is Dr. Adam Zolotor. Adam is professor of family medicine at the University of North Carolina and has had a distinguished career. I think I can recite some of his credentials. He has a MD and MPH from UNC. He did family medicine at Michigan and then came back to UNC and was on the faculty and has a doctorate in public health as well. And Adam and I have worked collaboratively a long time. We got involved in what he's going to tell you about today, this program. He may be the only family medicine faculty member who was a regular consultant on the pediatric service because he took child abuse call with us as part of the regular call rotation. He's also served as a person who helped run the statewide network of child abuse physicians in the state called the Child Medical Evaluation Program in North Carolina. He probably has more than this, but I counted up 53 publications. So he's doing pretty well on the publication side as well, and has been a star at UNC. And when I once approached him about coming to Colorado to be at the Kemp Center, I couldn't get him to leave North Carolina. So this is the closest I've got is to come speak at the Kemp Center. So Adam, you're on.
Thank you, guys. So let's see. I kind of like to wander. Does this work, Mary? Okay. So let's see.
This little button here should.
Testing.
Oh, maybe the battery's died. Here, you can use this one.
Okay. All right. Sort of Donnie style, right? Testing? Okay, good.
And then,
perfect. So, Des, thank you for the kind introduction. What he didn't tell you is that we've been working together for 23 years, which means that we're both 23 years older. I should let you know, and some of you have heard me talk about this. I spend a lot of my time these days working on state health policy issues, running a quasi-state agency in North Carolina called the North Carolina Institute of Medicine, and so have grappled with a lot of issues around the intersection of child maltreatment prevention, family well-being, and state health policy, and would be thrilled to talk to any of you about those issues. And before I start, I want to make a public service announcement because it would make me really sad if I couldn't find my USB drive. So there are 2 USB drives up here. I noticed when I was plugging in. One of these yours, John? Oh, good. Well, they have homes now. That's really good. See, if you attach your keys to your USB drive, then you can't get home without your USB drive. So that's one strategy. I'm going to talk a little bit this afternoon about the period of purple crying in our work in North Carolina. And Des was one of the chief architects of this and deserves a lot of the credit for this work. We have a long list of collaborators, including partners at Duke and UNC in the National Center for Shaken Baby Syndrome. And there's a list of the sort of the main folks that worked on this project with us over a period of 5 years, probably from about, what, Des, 2010 to 2015. And so much of this information is not new to some of you, but I want to at least give a little bit of context, knowing that about half of you have clinical backgrounds and half of you may not have clinical backgrounds. So some of this may be a little bit redundant, but you all have heard of abusive head trauma or shaken baby syndrome. It's been described for 47 years at least. And it's characterized by subdural hemorrhages associated with retinal hemorrhages and long bone fractures. About a quarter of cases are fatal, and among survivors, developmental, neurologic, and cognitive sequelae are the norm and can be severe. The rates of shaken baby syndrome have been pretty clearly elucidated in a variety of population health studies. The data we're reporting here is from Heather Keenan's study in North Carolina, 17.9 per 100,000 in the first 2 years of life, or about 30 per 100,000 in the first year of life. And that's similar to rates calculated in a variety of jurisdictions around the world. The sort of impetus for this study came out of work done by Diaz published in 2005 and Altman published in 2011, showing that a large-scale, universal, population-based shaken baby prevention program can pretty markedly reduce rates of abusive head trauma. And many of you have probably seen these papers. I think that these were pretty seminal papers in helping us think about what a universal population intervention might look like and might it work. I think that what we would say in 2019 is that these had some methodologic challenges and some methodologic challenges that we sought to overcome in our study. And mostly the most important thing about their study is that both of these were basically pre-post designs. And so they were comparing what happened before the implementation of a universal program to what happened after the implementation of a universal program. And hopefully after a couple of days of discussion of methodology, you all understand that that can be confounded by what else is happening in the world. So what we didn't really well assess is what's known in geeky bios terms as a counterfactual. So we didn't really know where these jurisdictions would be at without the intervention. So a third study published by Heather Keenan in 2010 looked at abusive head trauma in Utah and used case control design to try and understand if babies or parents exposed to the prevention programming, similar prevention programming, were less likely to be victims of abusive head trauma. And she actually found the opposite to be true. She found that infants or parents of infants exposed to the control condition were less likely to be victims of abusive head trauma. So this cast some significant doubt on the validity of the findings from the 2005 and 2011 studies. The program that we used was a period of purple crying, and hopefully some of you have heard of this. This is a program that was designed by Ron Barr from University of British Columbia in Vancouver in conjunction with the National Center for Shaken Baby Syndrome. As we were fond of telling people in the early part of the 2010s, it doesn't stand for the color that the baby gets when the baby is crying, but each letter in purple stands for characteristics of normal newborn crying that can be incredibly irritating and set off some parents to do some horrible things to babies. So the purple stands, the first P is that the babies look like they're in pain. The U is that the crying is unexpected. The R is that it resists soothing. The second P, does somebody help me out? Second P. Peaks 2 to 3 months of life. The L is long lasting, and E is for evening. It clusters in the afternoon and evening. So what we used to describe as colic are the typical characteristics of purple crying. And we sought to implement newborn education in every hospital and birthing unit across the state so that every parent would get exposed to the period of purple crying in North Carolina, starting in 2009. And we conceived of this in 3 doses, thinking that parents that were exposed to messages in education a little might retain some, but if that messaging was reinforced at later points in an infant's life, especially in the first few months of life, they would be more likely to retain that information. So dose 1 was that every baby would be shown the period of purple crying in the newborn nursery. They would also be given a copy of the DVD and booklet to take home with them, and be encouraged to review the material as needed and share it with other substitute caregivers. Dose 2 was that the information would be reinforced at doctors' visits during both well-child and sick visits in the first 2 months of life, and we would use a variety of materials, posters, cards, and replacement materials to reinforce the message. And dose 3 was a media dissemination campaign, and we did a couple of different things with the media dissemination campaign. I'm not going to talk too much about that today, but basically we did about a 6-month radio messaging campaign in 2 large media markets to reach saturation of messaging. And then we did a few statewide earned media campaigns to increase exposure to messaging around the period of purple crying. And as it turns out, we had, I don't know, Des, about $150,000 for our media campaign. And when we sat down with our colleagues from the School of Journalism and Mass Communication, they gave us a $6 million budget. And so we said, well, what could we get for $150,000? And this is about what you could get for $150,000. So let's see. I think, I'll just call out our funders, the Centers for Disease Control and Prevention, the Duke Endowment, and Doris Duke Charitable Foundation. and jump right into the method. So I'm going to be sort of describing a bunch of sub-studies that help us better understand some of the components of the intervention, fidelity of the intervention, and some of the ways that we analyze the outcome of the intervention. And so we'll sort of take this in steps. So we implemented in 86 hospitals and birthing units. Our implementing partner was the Center for Child and Family Health, which is a consortium of Duke and UNC and NC State. And they were responsible for all of the sort of groundwork of meeting with hospital nursing staff and educating nursing staff on delivering the program, and did a fantastic job at implementing in all of our hospitals and birthing units. There were sort of, as you would expect with this kind of program, early adopters, and then there was kind of a phase-in stage where we were getting steady buy-in and new hospitals enrolling all the time. And then when we were about 12 months in, we had about 8 or 10 hospitals and birthing units, are sort of stubborn hospitals and birthing units, and that's where we would call in Des and Frank, right? I mean, we had like a senior statesman pediatrician who was probably 78 or so at the time, Frank Loda, and he would go in and he knew somebody at every hospital, and he would just call up the right person and take care of it, and we were able to get into every hospital and birthing unit. I was being a little bit more politically correct than that, but yeah. We would call him Frank, and we'd like, I don't know what Frank's bringing. I don't know if he has a baseball bat in his bag, but he takes care of it. So, so we did phone surveys with staff at 6, 18, and 30 months to assess program implementation. We also did group interviews with nursing staff at all of our hospitals and birthing units at 12 and 24 months to assess fidelity, and paper and pencil surveys following training and at 12 and 24 months. So we had a lot of touch points with staff to understand what they were doing. We knew what we asked them to do. We asked them to do a bedside script, and we gave them 2 different options, a 60-second script and a 3-minute script. And we knew that they weren't going to read that card all the time, but our hope was that they would deliver the key messages. And we'll talk about those key messages in a few minutes. We also asked them to press play and make sure that every new mom was able to watch the video, hopefully with partners and other caretakers present, but at least every new mom. And we know that, in some hospitals, they had DVDs in the room, so they were or DVD players in the room. Other hospitals wanted to put the Period Purple Crying on their in-house loop. We facilitated that. And in other hospitals, we bought them DVD players because they didn't have them readily available. They would be on a cart, and they would wheel them into the room. Those things walked away periodically, so we had to replace DVD players throughout the project. But again, the nurses were supposed to give key messages, press play, and then give materials to take home. So those were sort of the 3 components of the hospital-based intervention. And we wanted to assess compliance with program protocol or fidelity to our model, and also program adoption, staff satisfaction, and integration of the program with hospital workflows. So this is nurse-reported adult to doing the bedside teaching. So this is, we told nurses to do the bedside teaching. This is asking them, again, at 6-month intervals if they did do the bedside teaching. And so you should certainly take that with a grain of salt. This is self-reported data, but shows that nurses think at a pretty high level. So in the unit of analysis is the hospital. So the blue bar, the bottom blue bar, shows us that 80% of hospitals at 6 months say that they're doing bedside teaching 95% of the time. And so really, for the most part, almost all of our hospitals are in the either greater than 95% or 85 to 95% of the time for self-reported bedside teaching. So we thought that was pretty great. Similar results, a little bit more in the 85 to 95% are reporting that they're essentially pressing play so that the parents can watch the DVD. But if you look at 30 months and add the light blue bar and the Tar Heel blue bar and the Duke blue bar, you're getting up to about 90% of hospitals are reporting either 85 to 95% or greater than 95% of the time that they're pressing play and having parents view the video. This is for distribution of program materials, and this is again from Nurse Report, and shows us again. So if we look here at the 6-month bar, we have about 57% of hospitals saying that they're distributing materials greater than 95% of the time or between 85 and 95% of the time. And we had some ways of doing statewide estimates. So we were a little bit less good with distribution of materials, and there was a lot of, at least what we heard throughout the course of the study, parents say, I get it, I don't need those materials, or, I already got that during my last birth. This is a 5-year program, so we had a lot of parents that didn't want to take another set of materials, which I think makes some sense, but makes it hard to do your program evaluation. And this is median distribution, mean and median program material distribution. And so you can see the median, throughout the course of the study based on nurse self-report was in the 90+ percentile. So nurses thought they were doing a pretty good job of distributing the materials. And this pretty much says the same thing. I want to just go to staff satisfaction. The nurses were asked what they thought of the program and how much they like delivering the messages. We asked them, how helpful do you think it'll be? How useful will this information be? And how does this program compare to other programs for the prevention of shaken baby syndrome? And you can see these are 5-point Likert scales, 5 being very helpful, and 4 being helpful. Nurses thought that the information was helpful, useful, and that it compared favorably to other prevention programs. And this slide sort of got a little bit mucked up, but this is how useful do you think this is to parents? And if you go to the 24-month box, 63% thought it was very useful to parents, and 32% thought it was useful or somewhat useful to parents. So this is a slide about documentation in the medical record, and we thought this was an important step for implementation in workflow, so that a program could continue after the research and implementation team exited the program. And we see that by 30 months, 98% of health systems reported that there was a workflow protocol for documenting delivery of key messages or distribution of the DVD or playing the DVD. So our conclusions from this was that hospitals demonstrated high fidelity to program protocols across measurement strategies, understanding that those measurement strategies were not without limitation. I'm sorry, so one of these slides, this slide, I failed to, I think I said this incorrectly. If you look at the heading on the table, this is not nurse report, this is using program, this is using inventory. So we had each hospital do an inventory on a quarterly basis so we could understand how many DVDs we sent them, how many they had left, and how many births they had in that quarter. And this was, with this information, we're able to demonstrate which hospitals were, again, distributing DVDs to 85 to 90% or greater than 95% of their babies. And we had pretty good success. Our sort of statewide averages, this is also from inventories, not self-report, was again in excess of 90%. So based on a different method of collecting data, we found that hospital staff were doing a good job of distributing program materials to most families. Again, we documented high staff satisfaction and systematic documentation in the hospital medical record. We wanted to know, though, we had in a complex program evaluation, we wanted to not only know what nurses said they did, we would have really liked to have known what they really did. That winds up being kind of the hardest thing to know. But understanding what parents remember learning about is another useful strategy for getting to the truth. So we did, we had a variety of ways of assessing parent recall. And I'm gonna just jump to the next slide. So I think that the most interesting data point was a telephone survey of nurses of parents of infants. And we targeted parents of infants 9 months of age or less. And we did this by back matching on birth certificates. So we knew which babies were born during a given period of time. Working with our State Center for Health Statistics, we're able to get enough identifying information to get phone numbers on these women, and had a stratified random sample, and we're able to interview 1,644 parents with an adjusted response rate of 52%. We really wanted the infants to be as young as possible because we thought if the parents were 6 or 7 or 8 months out from birth, they might not remember what happened in that birth hospitalization. So we were able to get infants with an average age of 3.3 months. So we were pretty happy with the sample construct. And we asked parents if they had ever heard of the period of purple crying, and found that phenomenally 80% of them had heard of the program. So 1,300 of our 1,600 parents knew what the period of purple crying was. We asked them where they heard of it, and not surprisingly, 93% of them heard about it in the hospital, 9.7% in a doctor's office, 8.4% in the media, and so I think that goes to our other sort of dose 2 and dose 3 dissemination strategies. And we asked them what they remembered, and we gave them options, and there were there was a sort of a blank response option, but we asked them, which of these were the key messages of the period of purple crying, and 85% of them recalled crying is normal. Again, you can see these 87% shaking is dangerous. The lowest recall was about the normal peak of crying, but we're pretty thrilled that 83% watched the DVD at home, 73% shared the booklet at home, and 80% shared this information with others. And Des remembers that I was really, really skeptical about giving a DVD and booklet to every parent. I think it's sort of like, I think my environmental guilt was making this really difficult, thinking about all the garbage we were creating. I mean, we handed out 600,000 DVDs, booklets, cellophane wrappers, etc. So this was like a lot of garbage, and garbage well worth making if people are really using it. And I was just really delighted that people reported that they really valued having the material at home, were rewatching it or reviewing the booklet, and were sharing it with others. So 57% of parents reported watching the DVD in the hospital. Again, that speaks to program fidelity. We don't know where truth is. 90% of nurses reported that they were pressing play. 57% of families, of parents remember watching the DVD in the hospital. And 73% of them watched it with somebody else in the room. Again, so that's trying to get to other caretakers. 84% of parents received their own copy of materials. And you can see 34% watched the DVD at home, 62% read the booklet at home, 25% showed the DVD to others, and 30% showed the booklet to others. So we thought that was pretty great that, going that extra step and distributing the materials seemed to be useful. We also asked them sort of what they thought about the material and how that impacted them. And you can see that, again, these were 5-point Likert scales. And these are parents that either agreed or strongly agreed with the statements. Helped me feel less frustrated when my baby was crying, 91%. Helped me understand my otherwise healthy baby's crying can be normal, even if it goes on for hours, 87%. And made me less stressed when my baby was crying, 86%. So you'd say, like, that's pretty good. If I could do a program that, costs, what, $2 per parent, and I could get that many parents feeling better about parenting, that's pretty great. These are just some bivariate analysis. You can see here that we looked at parents with less than a high school education, and they watched the video at much higher rates than those with a graduate school education. Over here, this is similar, sharing the video. The more educated parents were less likely to share the video with other people. And then this is by race and ethnicity. And let's see, so here you can see using a booklet was most common among Hispanics, and sharing the video was most common also among Hispanics. So our conclusions from this parent survey was that recall of key messages was high, the use of materials at home was high, and that there was some differential use and sharing of those materials at home by education and ethnicity. So the hospital is the most common place for parents to recall learning about the period of purple crying. Doctor's office and media campaigns represented a small potential for reinforcement areas, again, subject to limitations of budget and staff. And despite the small cost, the distribution of materials seems important in abusive head trauma prevention education, given the high rates of using materials post-hospital discharge. So then we wanted to know, did we make a difference? Did we actually change rates of abusive head trauma? And our hypothesis was that victims of abusive head trauma would be more likely to be born at a hospital with lower fidelity to the period of purple crying. So this is, I don't want to go too deep in the weeds, but basically we did a prospective cohort analysis and looked at babies that were born in hospitals with sort of, I'm going to say just for the sake of simplicity, high, medium, and low program fidelity to see if there was differential risk of abusive head trauma. And we used the entire birth cohort in North Carolina over a 4-year period. So we had 664,000 newborns born over that period, and 82 cases of traumatic brain injury, 138 cases of abusive head trauma. And we used TBI and the entire birth as comparison so that we had essentially 2 comparison groups to our abusive head trauma case group. And you can see our rates of abusive head trauma, and this is for kids less than 2, was 20 per 100,000 person years. And if you recall in the earlier study, which we used as a reference, the rates for kids under 2 was about 17 per 100,000. So our rates post-implementation of period of purple crying were higher than our rates in Heather Keenan's study from around 2005. And so what we said was, well, maybe the problem is that we're in the midst of the largest recession since the Great Depression, and so maybe there are other things happening. Maybe it's a problem with timing, right? And I think that makes sense. I think when we have either positive or negative studies using this kind of methodology, we should look for alternative explanatory models. Again, we asked the question, if you have fidelity to the model, is there an increased or decreased risk of abusive head trauma? So we used the nursing survey for bedside teaching, viewing the DVD, and distribution of program materials. And we calculated incidence rate ratios. And you can see, so hospitals with high fidelity to teaching were had an incident rate ratio, or which is basically a risk ratio, of 1.16. That kids were more likely to be victims of abusive head trauma. It's not statistically significant, so it doesn't matter, but it's actually an incident rate ratio in the wrong direction. So what we found was that with watching and teaching, the incident rate ratio was in the wrong direction. With giving, the incident rate ratio was in the right direction, if you will, but none of them were close to being statistically significant. So we found really the message was that attention to the program model and high fidelity did not make any difference in abusive head trauma rates. It actually seemed to make more difference in traumatic brain injury rates or unintentional traumatic brain injury rates, which doesn't make any particular sense. The other thing that I just want to call out is we did do a model with all 3 of these. So with hospitals that have high fidelity to teaching, watching, and giving, are they more or less likely to have cases of abusive head trauma? And it also didn't make any difference. So not super exciting findings, right? And I think I said all of that pretty much. We also did a study. This was Dez's idea. I think this is pretty clever. We wondered if parents were more or less likely after implementation of the study to need advice about newborn crying. And UNC operates a large kind of nurse helpline to support a lot of the practices in North Carolina. Not all the practices, but a lot of the practices. The service covers 68 pediatric practices statewide, and they were able to pull calls on infant crying before and after implementation of the period of purple crying, and found that there was a 20% reduction in calls for 0 to 3 month olds and a 12% reduction in calls from 3 months to 12 months for newborn crying not associated with a fever after implementation of the period of purple crying. So you could say, well, maybe parents knew more about the period of purple crying and maybe needed less help or less advice around normal newborn crying. Ultimately, we used, and we mentioned this morning in course 1, a difference in difference model to try and understand whether or not we made any difference in our outcome. And so this is a type of a time series, interrupted time series analysis using an econometric model to understand how our rates change over time in North Carolina and how that compares to other states selected for comparison. And I don't want to go too much into the weeds on this, but basically to select comparison states, we wanted to find states where the slope of change before the implementation of the period of purple crying was about the same. So you wouldn't want to pick a state for comparison that was having drastic decreases in rates before we implemented the period of purple crying, because it would make it a lot harder to understand what was happening. We also, we were also limited to states that data was available, okay? So, and not only available, but data that was available that was relatively cheap. So there's hospital discharge data available through AHRQ, and at the time, the cost per year of data ranged from $50 to $5,000, and we wanted about 10 years of data per state. So the states that were charging $10,000 or $5,000 per year were states that were cost prohibitive. We also tried to select states that were not implementing universal prevention programs because we wanted to have less sort of environmental confounding. We wanted to pick things that, we wanted to pick states that were sort of humming along like North Carolina, that hadn't tried to implement a universal program. We also controlled for mortgage foreclosure rates and unemployment rates by state based on other data that, other papers that had shown that these things are associated with rates of abusive head trauma. And this was sort of our bottom line answer. This graph, if you see the solid, it's the dashed orange line in the middle is North Carolina. And you can see that the line goes up and the line goes down. We implemented the program in 2009, which is, you can see the arrow in 2009. You can see the rate goes up a little bit after implementation, then the rate goes down a little bit after implementation. And you can see that we're comparing on this chart to Arizona, New York, Colorado, Maryland, and Wisconsin. And there's no change in our rates of abusive head trauma when compared to these 5 other states in a difference in difference model. And so our sort of bottom line conclusion was that the period of purple crying really didn't make a difference in abusive head trauma rates in North Carolina. You can see we showed our abusive head trauma rates in North Carolina ranged from 25 to 45 per 100,000 over an 11-year period of study. Pre-intervention rates on average were 34 per 100,000. Post-intervention rates on average were 36 per 100,000. That's pretty similar to our comparison states, both pre and post-intervention. And the adjustment made no difference. The adjustment for mortgage foreclosure and unemployment, which you could imagine varying by state. And so, as you can imagine, we weren't super duper thrilled with our results, but wanted to report them honestly. I can tell you that the CDC was funding 2 programs, 2 statewide programs. Mark Diaz had moved to Pennsylvania. They were funding an implementation and evaluation program in Pennsylvania that was sort of I don't know, in friendly competition with the program in North Carolina. His study was also negative. It showed no difference in their implementation of a universal shaken baby prevention program. And so our bottom line conclusions were that, that we implemented the intervention with high fidelity. Dose 2 and 3 were extensive, but less systematic and less comprehensive. There was excellent parent recall, some change in parent behavior, and we pointed to the use of the nurse advice line as a change in parent behavior, and no change in demonstrated abusive head trauma rates. And I think in playing, Monday morning quarterback about why is this a negative study, I think that there were a variety of things that we definitely talked about. Is it possible that it takes more time for culture change? Is culture change a big part of, getting out a message like the period of purple crying to impact abusive head trauma rates? Maybe. However, we didn't have time, we didn't have resources to continue to send hospitals DVDs, continue to monitor program fidelity, and support hospitals in implementation. So though we could look at subsequent rates of AHT, we wouldn't really be able to associate them with our program, because our program, as an implementation and evaluation program, basically ended in 2015. I think we also wondered if there are parents that have a higher degree of risk that are more likely to be perpetrators of abusive head trauma that need intervention that is at a higher level than what amounts to a 10-minute video, a minute of bedside teaching, and maybe some reinforcement messaging along the way. And I think that that's a real issue. What does it take to change behaviors in the lives of families, for families that are highly impacted by stress and risk? So hopefully I have a little bit of time for questions. I actually think we have about 10 or 15 minutes. So think about questions in terms of study design or our findings or how we interpreted them. Yeah.
So the thing that's most surprising to me is the high rate of implementation fidelity. I know, especially in social services, that implementation is very hard to be successful on any scale, even with important issues or evidence-based models.
Mm-hmm.
So I'm curious as to how you explain that surprisingly high rate on such a huge scale.
Yeah.
What factors really contributed to that high fidelity, and was there a need for de-implementation of other strategies that the hospitals may have already been using prior to this?
Those are great questions. So what accounts for our high degree of implementation? And I would say there are a couple of things. I think that number one, we had about $2 million for implementation over a 5-year project. I'm getting that about right. And so that's a fair bit of resources when your unit of implementation is really focused on hospitals, and there are 86 of them. We had a staff of about 4 full-time equivalents that varied a little bit over time from 3 to 4, but we had a good number of staff for those 86 hospitals. We also, I think, have a pretty strong network in North Carolina. I think, Des and I knew many people, and Frank knew many people at all of our hospitals and birthing units. I think that relationships matter when you're working on implementation. We went to virtually all of these hospitals and birthing units. Not we, but actually we went to some because we thought our face time was important. The principal investigator of the implementation arm went to some, but people on the implementation team went to, I think, every single hospital to do training. We did a lot of positive reinforcement, like purple cupcakes and purple cookies and purple stethoscopes. And what else did we give them? We did newborn baby caps. That was one of our media, our earned media campaigns. But we did a lot to try and reinforce the socially desirable behavior of participating in our program. And so I think that helps. I think it was investment. It was network and relationships, sustained effort over time. You want to add something?
Within the hospitals, there was some failures in getting the hospital to really engage early on. So we adjusted our strategy and went to the CEOs and developed a memorandum of understanding about the study, because we found that the nurseries are very hierarchical. And if the head of the hospital had said, this hospital is going to be part of this, that left the nursing staff in charge of the neonatal or the nursing unit. They understood they were doing it, and they marched to those orders. So we took advantage of kind of the hierarchy of hospitals.
And that made me think we also used peer pressure. So if hospitals in your region were implementing, we gently used that to entice you to implement. In terms of de-implementation of other strategies, I sort of vaguely remember some discussion of, hospitals that had implemented a different strategy. Most of them were homegrown strategies and pretty easily given up. So it might be a card that they had that they put in the bag when they were discharging new moms. Some might have implemented out of the box, like Elijah's story kind of strategy. But I think that the fact that, our product was good, it had been well researched, we were giving them all the materials, all the training support. I think it was easy for them to buy into this. If they were already doing something and already thought that it was part of their job to participate in shaken baby prevention education, I think it was a pretty easy sell. I don't think we had any problems really with the implementation of other strategies. Yeah.
I was just gonna Camp Lejeune, the Naval Hospital, was a little bit of a problem because the folks in Washington had said that Elijah's story was going to be used as their prevention program, Mark Diaz program. But we just basically said, we're doing this statewide. And they said, oh, that's not a problem. And they switched pretty quickly.
So I think we had 2 military hospitals, and we included them in our sample. So yeah, I think.
Just which state has the lowest rate of abusive head trauma and why?
I'm not going to be able to answer that off the top of my head. Anybody know what state has the lowest rate of abusive head trauma? Can't tell you. Somebody might know that. I just don't know that. I mean, we've looked at regionally, and Northeast and Northwest have lower rates than Southeast and Southwest. Not by a lot, but by a little. I haven't looked at individual states. You know, and the reasons for it, I think I can only guess. Mm-hmm.
So what are they doing?
So that's Maryland, and probably they, of those states, are the least economically distressed, would be my guess. That'd be my off-the-cuff guess. I would have to like think a little bit more about that. I don't think that there's any systematic approach to abusive head trauma prevention that I know of. If anybody knows differently, call me out on it. Okay, so I saw some other hands up. I saw somebody back here. Okay. Yeah.
Hi, wonderful presentation. So the parent recall was amazing, but my immediate thought is people lie. And so now, since it was a different time, I guess my thought is like, do you think that re-implementing it with some newer strategies where you can check how, you know, if they really did watch it, at what point did they stop watching it? I mean, you can do all that with YouTube analytics automatically now. So do you think that that would give you kind of different results or might be a good, you know, future direction?
It's a super good question. And when you said, you know, people lie, it actually made me want to come back to the earlier question that I think you asked about fidelity. I think that that was my other explanation for the high degree of fidelity. I think that nurses tell you what we want to hear, right? I just think that, I mean, we all do that when we answer surveys, and I think that parents are doing the same thing. So I think that that's, you know, kind of brilliant. I think that, you know, thinking about, you know, the analytic capabilities of the year 2019 is kind of interesting. I think that the question would be really, do we have like enough evidence that this is a promising practice that we want to invest in a new research and evaluation program? Can we justify it, or is there another way we should be spending those resources? So I do think that there's more that we could do to more accurately assess parent, you know, certainly parent use of the program than we did. I think that you know, part of the strategy of the booklet and DVD coming home as a package is that people consume information in different ways. And you saw, like, I know that if you gave me both and my kid was crying and I didn't know very much about it, I'd flip through the book because I could probably do that in 30 or 45 seconds, and the video would take me 10 minutes, and I find the video, I've probably seen the video 20 times, and after 15 times I find it annoying. So I do think it would be hard to tease out some of those differences, but I think you could certainly learn more about what parents are doing at home from using you know, Google Analytics and YouTube Analytics. It's an interesting idea. So I'll go sort of this way. How about?
I'm just curious about comparison. You show how people with more education watch and distributed materials less frequently, but do have distribution how this trauma was distributed among by the education of Ma?
Super duper question. And in this study, we did not report anything about parent education. I'm trying to think if we have that data. The only thing that we probably have is payer status, which is a, you know, kind of a weak proxy for parent education. But we only have what we abstracted from charts from the abusive head trauma victims, and don't have any information on parent education degrees, you know, completed degrees or anything like that. In this study, we chose not to. In Heather Keenan's study from a decade earlier, she chose to. She followed those kids until they were at least 3, right? Do we know anything about parent education from Heather's study? I can't remember. either parent education or payer status. Yeah, I don't recall. It's a good question, and we could look at Heather Keenan's paper from pediatrics to see if she was able to untangle any of that. But we did not follow any of these kids.
I have a few questions. So first off, though, I'm just thinking with the proximity, you guys did the video, the program, while the parents had essentially, or while the mother had given birth, like right after. I'm wondering, because that's such a stressful time, if you guys had thought about doing it beforehand or even afterhand, delaying it so it's not as stressful, maybe for better recall. And along with that, there would be, if maybe you've talked about doing like a pre and post knowledge test, because I could see I feel if you're checking off the boxes, it'd be easy, like, oh yeah, I do remember that bit once it's fed to you. So again, you probably would know more with that. And then also if there are any characteristics or the benefits by like education race, because there were differential rates of whether people watched the video at home or read the book, if there was anything with that knowledge recall too about by race or by their education levels. That was a lot.
Yeah, so I'll try and go backwards. So we didn't look at knowledge recall by education, race, or ethnicity. So we could do that, but we didn't do that. The question about where this intervention is best delivered, I think, is a super fascinating and important question. I think, what do we have a word for, like instead of a reinforcement dose, we called it a pre-enforcement dose. So there were some obstetricians that wanted to participate in sort of the dose 2 equivalent, or some birth education programs that wanted to participate in the dose 2 equivalent, that we were delivering this programming before delivery. I think that's a super good thought. You could imagine the pediatric medical home being another place to deliver this kind of message. And not only is there this like challenge of so much has happened during the birth hospitalization. You have pain and blood loss and exhaustion and initiation of lactation, all that stuff. It makes it a terrible time for teaching, and we're trying to throw so much at these new parents. But why do we throw so much at these new parents? Because it is the place where we have them as a captive audience. If we wanted to do this in every pediatric medical home, that would include, pediatric practices, family medicine, health departments, and FQHCs. I think they number in the 2000s in North Carolina versus 86. So it just becomes a really, really difficult implementation challenge. But I think that you may be right. I think that we don't know the best time to deliver this education. What we know is that we think this is kind of when we can do it in a systematic, universal way. You had one more question. I answered your first one and your third one, but I forgot your second one.
I think you said if there were benefits by education.
Got it. Okay, very good. And I saw some hands up this way.
I had a question if you knew anything about when the program was initially created, if there was any kind of parent involvement in the creation of the program itself.
So the Peer to Purple Crying was the culmination of years of focus groups, parent testing, message testing, and a really, and Ron Barr is a developmental pediatrician who has studied infant crying for 30 years. And so lots of parent input on the ultimate and revision. So the jacket I showed you was sort of the beta version, but it's not nearly as dorky looking in the version of the video that we distributed. The parents got like a lot less dorky. It was very multicultural. It was I think a well done program and message tested with a marketing and PR firm. So I think they did a good job in program development.
I'm curious. I know you mentioned in the beginning that the rate was about 30 per 100,000, and curious how that compares to other burdens of death or disability in infants, because I'm wondering if this is something that is of interest because it's so easily preventable, or if it's because it's such a large burden.
So I would have to do a little bit of quick math. So if the infant mortality rate is 6 per 1,000, that means that it's about 600 per 100,000. So we're talking about, just to, again, rough numbers. So it's 5% if my mental math is accurate. My mental math is usually pretty good. So 5% of the infant mortality rate is the AHT rate among infants. most of infant mortality is in the first 30 days. Most of it is related to either prematurity or congenital anomalies. So you get about a third of everything else that's not one of those two categories. So it winds up being probably a pretty big deal. I think that in terms of like arguing for prevention, I think though that you're right on. I think that like, it seems like, and we don't know exactly what the right intervention is, but it seems like some combination of helping parents to have a longer fuse, to know about dangerous behaviors, to help them build coping strategies, that there may be opportunities for preventing shaken baby syndrome, which may be really different than some other diseases, congenital anomalies being a good comparison. And I think that, the other thing is, sometimes we talk about like, all right, so you're talking about 35 or 40 babies per year in North Carolina. Is that really worth it, or should we really be putting this money into intensive nurse home visiting, for example? And I think that there's an argument to be made. The difference is, number one, abusive head trauma victims are either dead or devastated, whereas other kinds of child abuse and neglect victims may have serious developmental and behavioral sequelae, but I think that they're less likely to be dead or neurologically devastated. And it's like relatively cheap. I think I mentioned that it was $2 per DVD. There was a lot of cost on, making this a scientific study, a lot of implementation support, and a fair bit of cost for evaluation. But you could do this for probably the cost of the DVD plus about another $2 per parent. So we talked about, $250,000 a year for 125,000 births. That's pretty cheap. If you compare that to an intensive parent home visiting program, you could serve somewhere between 20 and 40 families for that cost, right? So it's a size, scale, and scope issue. And if it was effective, this would seem great. This would seem like a really good deal. Yeah. No. Good exercise.
So I have a question. You mentioned that that this was a 5-year period, and some parents were having a second child or something like that during that period. Did you consider if any effect would be given to these parents that would go again and kind of get that? Because you're doing your 3 doses, but these parents are kind of getting 6 doses because they're going through that program again. You know what I'm saying? It's kind of like that reinforcement. Did you account for that reinforcement in your study?
So absolutely not. I think that it's like a really interesting question and methodologically really complicated. I think we just simply, even if we knew about birth order, say, from the birth certificate, we might not know the year of the last delivery. Without specifically asking. Now, we could have, in our parent survey, asked, we could have done a sort of a household inventory and find out, how many children lived in your house that were under 5 and where were they born and were you exposed to this the previous time? But we chose to focus on the most recent exposure. And that becomes, an issue of keeping your survey short for, the sake of completion, the sake of cost. Yeah. Good question though. Yes.
So, and I'm not exactly sure how to ask this question, but there seems to be sort of an underlying assumption that if enough people get exposure to the intervention, that it would have an impact. And I'm wondering if this is an issue with, sort of a conceptualization that, I don't know, has to do with something like herd immunity or something like that, and whether or not this is really the appropriate way to target a prevention approach for those individuals who would be at most risk for this. And I'm wondering if that's something that, you have any thoughts about as far as what you would do differently or how you might approach this problem differently.
So I think that what I would say is, we thought that there was a need for changing cultural norms around the way we parent, the way we react to parents. I mean, has anybody ever been on an airplane and given a dirty look to the parent of a crying baby? I'm sure nobody in this room has ever done that. But you've probably seen other people do that, right? And so I think that there was this sort of phenomenon that we wanted to normalize that parenting was hard, that parents need help, that, you know, the period of purple crying, one of the messages was around asking for help. We wanted not only to get this message to parents, but we wanted to get this message to grandparents and members of the community. And the marketing strategies were actually not targeting, you know, in terms of sort of our radio spots, we weren't necessarily looking for parents. We were looking for general population because we thought that the message needed to get out to a broader audience. So I do think that there was some like thought about the herd immunity, and I think it's like an interesting and open question. But I think if you want to ask me why I think it didn't work, I do think that it has a lot to do with the intensity of the intervention and how hard it is to change behavior. And so I think that if I were to do this differently, it would be more about identifying families at highest risk. I think that the challenge is that we have like some ways to identify families at high risk for abuse and neglect. We have some programs that we think are reasonably effective at preventing abuse and neglect. We haven't really connected any of those to the prevention of abusive head trauma, but have some good reason to believe that some of the same parenting skills and support and identification of depression and substance use that we do in those parenting programs would help those families. But those programs also have their own challenges, as you well know. I mean, you know, we've been talking a lot about program engagement. So if you offer a parenting program, how many parents engage in those programs? Are those the ones that need to engage in them? What's the dose intensity? What's the dropout rate? You know, most studies of nurse-family partnership, at 2 years, there are about 25% of families retained in the program. So I think we have a lot of challenges in prevention. But I ultimately probably don't think that a 1-minute bedside teaching and a 10-minute video is enough to change the behavioral makeup and the family system within which this baby is born. Yeah, I don't know. Anybody want to add or argue with me?
No, I had a question.
Yeah, go for
I don't
it.
want to argue with you.
All right. Go for it.
So I know like you had different rates of engagement from different ethnic racial groups. I was wondering if you had considered like stratifying the rates of actual like head trauma to see if there was any group differences, to see if maybe the fact that they shared it or seemed to be a little bit more engaged made a difference within those groups.
Yeah. So we did do demographic description of the abusive head trauma victims, but we didn't try to understand program fidelity by race and ethnicity, and I would probably posit to you that our cell sizes were too small to do that effectively. I think it's an interesting question, and I think the other part of this is that I don't think that we have like reason to believe that just the sharing or just the showing or just the viewing is the part of the intervention that makes a difference. But I think, but it might be. I think there was a hand up over here. Yeah.
Yeah, my question is more about the details about the study design, especially it's a 5 years intervention study. And I'm wondering, could you share some successful experience regarding how to promote the research surveys or the questionnaires you used when you evaluate the result, especially how to successfully keep the reliability and the validity of the study?
So are you talking about implementation or evaluation or both? Yeah. I mean, so I think that, so you asked about fidelity, or you asked about validity of the evaluation. And I would say that these were in-house developed surveys that were really, they sort of had face validity, like, did you hand this out? And I think people knew what that meant. These weren't validated scales. These we shared our evaluation materials with Mark Diaz in Pennsylvania and with Ron Barr, who's doing other work in British Columbia. So others may have used this, but I can't tell you that these were validated scales. I think in terms of getting people to fill them out, which I think is a real challenge in a lot of program evaluation work, is just how do you get people to participate? It was visiting these hospitals, it was feeding people. We bought a lot of pizza and it was sort of a convenience sample. So we might try and feed nurses pizza on 2 shifts. We might go late one shift and early during the next shift and say, can you please come? And we want to feed you pizza, and we're only going to ask you to fill out like 4 questions. So keep it short, feed people. And again, this is like, we had a fair bit of resources for both program implementation and evaluation. And we're lucky that way, because I think keeping people engaged is hard. And I would say that the validity of the instruments we used was face validity only. Yeah, good questions. I think that we're supposed to be wrapping up in about 2 minutes.
I was going to ask you another question, but I'll just comment that we also we talked to people who do the perinatal risk assessment module at the State Health Department to add newborn education about shaking. And so we also had their standard state surveys, which are used all over the country, also showing over 90% of the mothers got the materials according to that. So we triangulated from other directions. I was going to ask you to talk a little bit, but Ron Barr has since published in Child Abuse and Neglect a successful reduction in abusive head trauma in British Columbia with the period of purple crying, which is 1/3 the size of North Carolina in terms of population and delivery, and yet had successful outcome. But I also would ask you in the context, do you think the fact that they also have nurse-family partnership in every one of those homes might make a difference in terms of where that went?
Yeah, so I mean, I think that there are certainly a lot of things at play. I think that when you have a program champion who, the program developer, program champion, the biggest fan of the program, I think that the strength of implementation may be different. I think that, and we've seen this with lots of interventions. And I think that there's some really great things about being sort of the one who owns and designs an intervention. I think that there's some challenges when you also become the evaluator of that intervention. So I think that we should own that. And then I think that the context is just really different in British Columbia. I mean, I think that in Canada, the social welfare safety net is totally different. The universal home visiting is totally different. So I just think we have a lot of cultural differences. So it's possible that it was effective, but that it's not a comparable environment. So I think that what I'd say in the end is, do I think the period of purple crying is a good program? I actually do. I mean, I think, again, nurses like it, parents like it. Parents are showing that they think it's helpful. It helps them be less frustrated. They find that they understand normal newborn crying. And for $2, that's not bad compared to a lot of the things that we do, right? That's not bad. But I don't think that, our study points to a significant reduction in abusive head trauma in North Carolina. So thanks so much for the good conversation.
Just a brief announcement. We actually think for our funders' benefit that we should probably take a group picture. And we were thinking